Hi everybody. Today I want to speak about pharmacologic treatment for the COVID-19. I will try to explain about the disease and the pathological and the pathophysiological background of the COVID-19, and also I will try to review of the therapeutics about COVID-19. And in the end, I will try to summarize and briefly about the COVID-19 and how it can be treated. Coronavirus or COVID-19 or COVID-2019 first appeared in the Wuhan, China, in the last December 2019. It's belongs to the envelope type virus. It is a RNA virus with non-segmented 30,000 base positive sense RNA, and it is a family of the Coronaviridae. This type of the virus can bind to the ACE2 receptor, and as you know, in ACE2 receptor we can find in the respiratory system and GI tract and hepatic and other part of the body, but mainly in the respiratory system and the GI tract. Then it can infect the respiratory and GI tract, and it mainly can cause the hepatic failure, and sometimes it can cause the CNS problem. And the main problem for this disease is the SARS-CoV-2, or we can say severe acute respiratory syndrome. It belongs to the beta coronavirus genome. It has a 125 nanometer diameter. It's a big almost. And the genome of the disease belongs to beta COVID-19, beta COVID or beta coronavirus. As you know, we have 4 types of the genome for the coronavirus: alpha, beta, gamma, delta. And for example, in the alpha, the best example can be PRCV or HCoV NL63. Or we can find in the beta coronavirus we have SARS-CoV or MERS-CoV or MSV, and in the gamma COVID coronavirus we can have IBV, and in the delta we can have a PDCV. The coronavirus can spread mainly from the droplets, which primarily from the nose or the mouth, in the sneezing or coughing, and mainly it is in the air, and sometimes it can be caused by the touching of the contaminated surface. Is it possible? Because this type of the virus can stay in the environment for a long time. For the diagnosis, we usually use RT-PCR or real-time reverse transcription polymerase from the nasopharyngeal swab, because mainly the most important part for the spread of this virus can be from the nasopharyngeal fluid. Or in the clinical aspect, we can check the chest CT image. It's very important, because in the CT of the chest we can see how is the inflammation in the lung. The most important pathophysiological background of this disease, which I try to explain it is about how this virus enters the cell. It is one of the important things which can choose one of the best type of the treatment, because after the genome enter in the cell, but the process of the replication and the gene expression is important, because it can affect to the host cell genome. And the last step, the reverse transcription complex, helps to proliferation of the virus. And in the last step, it is very important, which the activation of immune system and the immune interaction with the APC antigen presenting cell can cause a big inflammation in the body, and it cause organ failure. As I spoke, the spread of this type of the virus primarily by the nose and the mouth secretion. sometimes it can be the touching of contaminated surface and then face. Typical clinical symptom of this is very important. The first most important symptom is the fever, and sometimes in the next stage can be dry cough and breathing difficult, shortness of the breath, sometimes because of the can cause inflammation of the lung, and sometimes can cause headache and pneumonia. Also, it can cause, in the last stage, it can cause progressive respiratory failure, which is very important. In some situations, they can cause the problem in the coagulation, and it can cause thrombosis, and sometimes it can affect in the heart muscle and can cause inflammation of the heart tissue and the damage of it. And in the GI, because as you know, the ACE2 receptor we can find in the GI tract, mainly can cause diarrhea, and also it can cause fatigue, loss of smell and taste. One of the best diagnoses symptom we can use and we can ask from the patient. But the most important situation, the patient after go to the hospital, sometimes we can't save the patient, because in every clinic the treatment is using some type of the protocols which is in the hospital, but mainly the clever doctors mainly use some common clinical finding about the COVID-19. We can use laboratory tests. The first important laboratory is CRP, because it shows how is the inflammation process in the body, how is the situation of the patient about inflammation. It affects for the lymphocyte cell, and it can cause lymphopenia, and the amount of the platelet can be decreased. Sometimes it affects for the liver and increase the ALT enzymes, and mainly can cause increasing of LDH and also CPK. And mainly it can affect for the leukopenia, because of it can decrease the white blood cell, because it can affect for the red bone marrow about the proliferation of the stem cells, the production of the white blood cell, but sometimes it affects because of the big inflammation can cause leukopenia. As you see here, the genome of the virus, it has two big parts. Non-structured protein sequence part, as you see, it has almost 30,000 base from the 5 to 3. As you see that from the 5, the first part is the non-structured protein, which they produce, which they produce a protein in the translation, which they can affect in the cell. For example, it can cause a proteolysis in the host cell, and the prevention of the effect of interferon, and also can cause viral replication and transcription. But in the other part, there is a structure and accessory protein, which this part can cause the synthesis of the protein, which we can find in the virus structure. As you see, inside the virus, it is envelope type virus. We can see a positive RNA, and the RNA bind to the proteins, which call a nucleocapsid protein. This type of protein has two segments. From the both segments, they can bind to the RNA, positive RNA. This type of the protein, nucleic protein, can help for the replication and transcription, and it has a two domains. From the both domains, they can bind to the RNA. As you see here, and the second protein, it is the A protein or envelope protein. They are assembly and morphological of the viral, and it has a pathogenic effect. It has a high relation with the genome of the virus, and plays a role in the viral budding and the viral envelope morphogenesis. It helps the virus go out from the host cell. And the third one is the membrane or matrix protein. It is the most abundant protein in the membrane, and it is most responsible for the shape of the envelope. And this type of the protein is the integral membrane protein, and as you see in the structure in the electron microscopy, it has an interaction with the S protein and M protein, and they have a high relation between them. The last part is the S protein or spike protein. It helps the virus interact. It helps the virus go inside the cell. There's a two type of the spike protein, S1 and this 2 subunit. S1 helps the binding to the host cell receptor, and S2 helps the fusion and the viral and enter the cell from the membrane. As you see here, from the non-structural protein part, we can see there is a two-part ORF1A and ORF1B. ORF is the operating frame. The first one, 1A, it has two main parts in the genome. We say papain-like protease, which helps the production and synthesis of protein inside the host cell for the proteolysis and interferon antagonist and also debiquitation. But the second one also we have a CCL protease. This segment of the ORF1A, it helps for the proteolysis. This part helps for the save and increase the resistance of the COVID-19 above the host cell. And the second segment of the ORF1B, it has two main part. As you see, after the ribosomal frame shift part, there is a RNA-dependent RNA polymerase which helps for the viral replication and transcription, and in the second part, ribonuclease, which helps to the ribonuclease. And here we can see in the structure and accessory protein the parts for the production of synthesis, the translation of the spike S protein, EMM protein. As you see, S1 domain is involved in the host cell recognition and the binding. It's very important because it helps to the binding of the receptor. And after binding this receptor and the effect of enzyme in the membrane, we will see in the later, and then the cell viral confusion inside the cell. As you see, the old summary of the structure protein of the COVID-19 in this page. As you see here, in the membrane of the COVID-19, there is this one outer, and it has a main trimer, and play most important role in the viral attachment to the host cell and fusion and tribe. But in the also, it is a short intracellular tail, and it has some part for the because transmembrane anchor, and also it has a large ectodomain that consists of the receptor binding. Here is S1 subunit and the membrane fusion S2 subunit. Mainly the S1 subunit contains a receptor binding domain. It's almost in the distal part of this protein which binds to the cell surface receptor. We say AC2, and it helps for the enter the cell. As I mentioned, there is two type of there is an enzyme which is very important, TMPRSS2. This type of enzyme helps to activation of this spike protein, because without this enzyme, its protein cannot bind to the AC2. For example, in one of the most treatment possibility for the COVID-19, we inhibit the effect of the enzyme we call TMPRSS2. As you see, the first step is the TMPRSS2 enzyme activated this protein, and then after that, ACE2 receptor can bind to the spike protein. Then TMPRSS2 or transmembrane protease serine 2 receptor enzyme, which belongs to the serine protease family, as I mentioned. And the SARS-CoV-2 is activated by the TMPRSS2. It primes the viral spike protein to allow viral entry into the target cell. For the prevention and the inhibition of the TMPRSS2, mainly we can use two types of the medicine. It is the nafamostat and the camostat. Nafamostat is a serine protease inhibitor. Mainly we can use in the hospital in the short-acting anticoagulant. Mainly we use for the treatment of the acute pancreatitis. It has a potential antiviral and anti-cancer properties. This drug also we can use in the acute pancreatitis, and also malignant type of the pancreatitis. And nafamostat is the potent antiviral inhibitor in the lung because it affects the inhibition of the TMP LSS2. And in the metabolism, nafamostat is mainly hydrolyzed by the hepatic enzyme. This type of the enzyme which we call the carboxyl esterase and the long chain acyl coenzyme hydrolase. It can affect for the nafamostat. As you see in the structure of this enzyme, it has in the first part of the molecule we have a ester part, which with this enzyme can be degradation of this part. And after degradation of this part, the main metabolized we can see PGBA and AN, or guanidinobenzoic acid is mainly important. And also in the camostat, in the second metabolism, this product can be also formed. And the second product is 6-amidino-2-naphthol. And the side effect of this drug, there's the nafamostat. Unfortunately, the agranulocytosis, hyperkalemia, and anaphylaxis maybe, and in the cardiac arrest, it affects in the cardiovascular system mainly, and also because it can affect with the increase in the potassium, and also it can cause of the effect of the ECG after cardiac arrest. Mainly we have to check the heartbeat and also the heart function after using of this medicine. As I mentioned, also camostat is the serine protease inhibitors, the same family. But the problem is this one, this type also the same effect we use for the pancreatitis, and it has a high potential antiviral effect. And also it has anti-cancer properties about pancreatitis. In the metabolism, as I mentioned, camostat mesylates, is hydrolyzed by the carboxyl esterase and convert to the 4,4-guanidinobenzoxyl phenylacetate. This is the first production then it can convert to the 4-guanidinobenzoic acid, the same metabolic product of the nafamostat. And mainly we can use oral dose between the 300 to 600 milligram per day. And the other drugs we can prevent for the attachment of the virus to the ACE2 receptor. We can use unifemavir. This type is prevent its protein ACE2 membrane fusion inhibitor, and mainly we use 200 milligram every 8 hours, and usually it is oral dose. And it can be used 50 milligram to 100 milligram tablet or capsule granule. But the other drugs is the chloroquine. It's main drug for the treatment of the malaria, because in this Africa this drug is used so much, and this is caused by the parasitis. As you see here, also with the second step, also chloroquine phosphate, also can help for the prevention of the enter the viral inside the cells. As you mentioned here, if you see here, these drugs partially metabolized by the liver and change to the desertyl chloroquine. As you see here in the picture, as I mentioned, chloroquine can inhibit the S and ACE to bind together, but sometimes the COVID-19 can induce cytosis in the cell and the formation of the endosome. But with the help of the chloroquine and hydroxychloroquine, which I mentioned in the last page, it can prevent endosomal acidification. In this situation, the endosome cannot be open, and the viral stay inside the endosome and can easily degradation. And as you see here, chloroquine inhibitor of the antagonist to convert ACE to receptor inhibitors, and also we use anti-malaria for the treatment of the malaria. And also the second, and also can prevent with help of hydroxychloroquine with the endosomal acidification for the opening of endosome. Metabolize, which what I mentioned, partially metabolized and partially can, without metabolize, can secreted by the urine. And we can find in this small amount of this ethyl chloroquine in the feces because it can go also into the bile duct. Normally chloroquine we use a daily dose around 500 milligram by the mouth every 12 or 24 hours. But we can find these drugs in the 250 milligram tablet or 500 milligram tablet in the salt form, but sometimes we can find 500 milligram tablets in the chloroquine phosphate and or which has a 300 milligram chloroquine base. And mainly for the dose we have to mention about the kidney function, and we have to check the creatinine clearance. But about the hydrochloroquine, as you see here, it's just affecting the endosomal acidification prevention, and the daily dose is 400 milligram by the mouth for every times 1 or 2 times a day. And we can find in 200 milligram tablet mainly in the salt form, which has a 155 milligram of the base of this drug. The other drugs which we use for this one is imatinib. Imatinib, as you see here, sometimes this viral COVID-19 can endocytosis inside the cell and the formation of the endosome. Imatinib can prevent endocytosis. It can prevent the entering the cell. Viral can enter the cell. And it is inhibit the BCR-ABL tyrosine kinase, which helps for the formation of endosome around the COVID-19. And after this type of the drugs, mainly metabolized by the hepatic, by the liver, by the famous enzyme which causes CYP3/4, and sometimes partially can metabolize with the site CYP1A2, CYP2D6, CYP2C6, and CYP2C19. The first problem is this one. After partially after metabolize, it becomes the active metabolize, which we call demethylated piperazine derivatives, which can cause a severe hepatic failure and a problem impairment. And it's very important because it is high, mostly increase in the bilirubin to 3 to 10 times, and it can cause a very bad hepatic failure. After the COVID-19 genome entered the cell, in the transcription of the negative strand, we can formation of the negative strand. We can prevent with the remdesivir and favipiravir. We can prevent to this transcription. And in this case, it is one of the most famous medicine which is now used in the hospital, because remdesivir and favipiravir can prevent formation of the negative strand nucleic acid. As you see here, remdesivir is also RNA-dependent RNA polymerase inhibitor, this protein, which is important, as you see in the genome. In the first page I explained in the genome of the virus, is an enzyme that catalyzes the replication of the RNA from the RNA template. It's very important because it catalyzes the synthesis of the RNA strand complementary to give a RNA template. And this type of the drug mainly we use with the infusion, and the remdesivir is usually given once per day and for the 10 days. But favipiravir is the same family with the remdesivir, but it is a prodrug which metabolizes to the favipiravir RTP, and then it can affect. Mainly we can use in the both oral and intravenous formulation, because it is a prodrug we can use in the orally also. As you see here, the next drug we use is 3C-like protease, as you see in the ORF or non-structural protein part of the genome. There is a genome which can produce this type of enzyme, and if we can antagonize, if we can inhibit this protein, okay, in this case we can prevent replication of this virus. For this case, we use a lopinavir, and you see the lopinavir and ritonavir mainly used for the prevention, for the inhibition of the 3C-like protein. In this case, the formation of the protein replication complex RNA-dependent protein also will be stopped, and in this case, the formation of the viral can be stopped. And mainly other drugs, we have a combination with the lopinavir and the ritonavir. It is both, we can use both of them, and this type also we use for the HIV treatment, AIDS treatment. And the protease 3CL protease is a potential drug target for the coronavirus infection, and it can help for the prevention of this type of the virus. And the other drug is the disulfiram. Mainly we use for disulfiram for the treatment of the chronic alcoholic person for the by production acute sensitivity to alcohol, because after when the patient alcoholic patient use the disulfiram when drink alcohol, it has a high vomiting, and it can in this case the patient cannot use alcohol. It can inhibit the papain-like protease, which the genome is in the ORF1 part, non-structured protein part. After the formation of the virus and proliferation increasing, the new virus can go out, and with help of the interferon beta, we can prevent this virus. But sometimes the virus can go in the body and can bind to the interleukin 6 and can cause the formation of interleukin 6, and in this case interleukin 6 can bind and can cause a hyperinflammation system. And the tocilizumab, or we say Actemara, and sarilumab, they use mainly for immunosuppressant drugs against interleukin 6, because when in the other situation, when virus enter the cell and the cell called APC, antigen presenting cell, in this case they can cause the formation of the cytokines, and increasing of the cytokine can cause the most problem. And mainly we use this type of the drugs for the treatment of rheumatoid arthritis. But the big problem, after the increase in the proliferation of the virus, they can activate the inflammation cascade with the increasing of interleukin and necrosis factor, and also they can activate the complement system. As you see in the physiological background, there is a 3 pathway which called classical lecithin alternative complement system, which the degradation of the C3A and activation onto the C3A and C3B, which can cause opsonization activation, and also activation of the C5. And from the C5 we can continue to the C5B and C6, C7, and they can cause a hole in on the membrane of the cell, and can cause cell lysis. And in the C5A and C5AI can cause inflammation and opsonization activation. Mainly they can cause increasing interleukin 6, 1, 8, 21, tumor necrosis factor, and CCL2 with the narsoplimab, which is the monoclonal antibody. We can inhibit the lecithin pathway, and with C1 inhibitors we can prevent classical complement system, because the C1 activation can start a classical cascade in the complement system. And with the AMY101 we can prevent the activation of C3, which is the inhibit onto it is an inflammation process by the inhibition of the activation of C3. And with IFX1 we can prevent the opsonization and the inflammation cascade, which helps to the prevention of the adhesion of molecule in the trine. And with the advoralimab, we can also use this drug for the prevention and the inhibition of the activation of the C5AR. And the receptor, in this case the receptor cannot bind for the C5A receptor A protein. And the last protein for this cascade is the eculizumab and the ravulizumab, which mainly can prevent to activation of the C5. In this case, the cell lysis will be completely stopped, and opsonization also partially will be stopped. And also ravulizumab is the same. It is a humanized monoclonal antibody for the prevention of the complement system. But the last part, it is for the activation of coagulation. Sometimes we see in the news or the hospital, the patient without any symptom can die very easily because of the formation of the thrombosis. As you see, SARS-CoV-2, because of the increased production of the interleukin 6 to 4 and tumorous active, it can make a storm of the cytokine. It can cause inflammation fastly, and can cause anaphylaxis in the body, can cause a shock in the body, and also it can activation the coagulation with the activation of the D-dimer FTP and increase APTT and the PT. As you see here, the activation of the cell inflammation because of this storm of the cytokine, it's pro-inflammatory cytokine increasing, and the situation shutdown of the fibrinolysis happen, and sometimes also it can cause coagulation, activation of coagulations cascade, and thrombin formation, and in the last step the fibrinogen can convert to the fibrin, and blood clotting can happen. And also it can cause with the P-selectin activation, activation platelet. In the last step, as you know, in the treatment of the hypertension, we use mainly drugs for the prevention and stop the renin and aldosterone system. As you see, as you know, the kidney can produce renin when we have hypovolemia and hypoblood pressure, and it can helps for the conversion of the angiotensinogen to angiotensin 1. Until here is good, because angiotensin 1 can convert to the by the ACE, which production by the lung can convert to the angiotensin 2 and 3. Okay, both of them can bind to the AT1 receptor, which can cause vasoconstriction and also increase the blood pressure and increase the production of the aldosterone and the ADH, but mainly also can cause pro-inflammation process and activation of the atrophy in the vessel, and can cause a tissue injury. But when the amount of angiotensin 2 and 3 is high, by the ACE2 receptor can convert angiotensin 1, 9 and 1, 7, which activated mechanism of the MAS receptor, MAS receptor. It is a tissue production because it is 100% opposite of the tissue inflammatory cascade of the angiotensin 1 receptor, and it has a tissue protection. When we have COVID-19, ACE2 receptor, because of the bind to the SARS COVID-19, can be inhibited, and in this case angiotensin 2 and angiotensin 3 increase in the body, and the mechanism of the inflammation will be faster and the tissue can injury. I hope it will be good, and I hope you will have a good time, and I hope see you in the next steps and the next video, and I hope it will be useful.